We'll go ahead and get started. So hello, everyone. I am Liz Lazo on behalf of the National Alliance for HIV Workforce Development, also known as NAHUD. I would like to welcome you to our monthly webinar series. I invite you to use the chat to introduce yourselves and engage with your fellow attendees. Before I introduce today's speaker, I'd like to go over some housekeeping items. So NAHUD is a membership organization of 8 regional and 2 national AIDS education and training centers. The AATCs, known as the AATC program, established in 2010, NAHUD supports the AATCs as a component of the HRSA-funded Ryan White HIV/AIDS program, which have an explicit directive to build and maintain a well-educated and culturally sensitive health professions workforce that can provide prevention, diagnosis, care and treatment, and medical engagement for people at risk for and living with HIV. NAHUD collaborates with multiple organizations in order to promote and educate on the work of the ATC program. Since 2018, NAHUD has been funded by the American Academy of Addiction Psychiatry as a partner organization of the Opioid Response Network, known as ORN, to address the intersection of HIV and opioid use disorder. ORN was created to support efforts in addressing the prevention, treatment, and recovery of opioid use disorder. ORN provides free resources and technical assistance locally in communities across the United States and its territories. So please visit the ORN website for more information in order to submit a request for technical assistance. So towards the end of today's webinar, we will include the evaluation link in the chat. We would love to hear your feedback on today's session and learn about other topics of interest you may have for consideration of future events. Unfortunately, for today's session, we are only able to offer C&E, social work CE, and a certificate of attendance. If you are interested in receiving one of these, you will need to complete the evaluation within 2 weeks. And just to let everyone know that we will be emailing your certificates, so please give us some time, but we generally get them out within 2 weeks of completing the evaluation. But any questions you may have, feel free to reach out to me at elazo@nahud.org. So at this time, it is my great pleasure to introduce today's speaker. Dr. Albert Garcia Romo is an assistant professor of psychology and behavioral sciences at the Johns Hopkins University School of Medicine. His research examines the effects of psychedelics in humans with focus on psilocybin as an aid in the treatment of addiction. His current research interests include clinical applications of psychedelics, real-world drug use patterns, diversity in science, and the role of spirituality in mental health. He is a founding member of the Johns Hopkins Center for Psychedelic and Consciousness Research and the International Society for Research on Psychedelics. He serves on the board of directors for the college on problems of drug dependence and is an associate editor for the journal Psychedelic Medicine. So without further ado, I would like to pass it over to our speaker.
Great, thank you. And I'm just going to go ahead and share my slides here so you all can see. All righty. And is that working okay?
Yes.
Okay, great. All right, well, thank you all for having me today. My name is Albert Garcia Romeo, and yeah, I'm going to be talking about psychedelic-assisted treatments for substance use disorders and mental health. Just start with some disclosures. I am a scientific advisor for a few companies, Neon Mind, Interwell, ETHA. Also have research funding from both for-profit organizations and nonprofit organizations and the National Institutes of Health. I'm going to go ahead and start by talking about psychedelics, and I want to do an introduction on the pharmacology of these drugs and their history, because a really interesting cultural history that kind of surrounds the work that we're doing here. And also talk about some of that clinical research that's happened over the last 20 years or so, as well as future directions, and then open the floor for questions. So today I'm going to be talking about psychedelics, which are a sort of subclass of what we call typically hallucinogens. And there's a few different types of hallucinogens, and that includes drugs like the dissociatives that work in the glutamate system, and the classic psychedelics that work in the serotonin system. And one of the things that's quite interesting about these substances is that they seem to have transdiagnostic therapeutic potential. And what I mean by that is it seems like we can use them to treat a number of different types of conditions, not just one type of depression, for instance, but depression and anxiety, and also different types of addictions as well. So I think that in itself is somewhat unique to these. But well, I'll also be talking about these as psychedelic-assisted treatments or hallucinogens as tools for mental health care. The reason I use these types of phrases is because it's not that we're just giving people the drugs and then they're getting better, like you're taking an Advil for a headache. It's much more complicated than that, and it actually involves a sort of milieu or a therapeutic intervention that involves the drug itself, the individual who's taking the drug, and the setting where they're taking it, which typically would include a therapy or counseling type of setting. And these all seem to combine in a way to create both these brain effects under the influence of the drug and these psychological effects that then lead later on down the line to persisting effects, things like improvements in mood, changes in personality. And then these often are associated with things like reduced substance use, therapeutic outcomes that I'll talk more about. So again, pharmacologically speaking, there's a few different subclasses of hallucinogens. I won't get too deep into all of this, but just to note, the dissociatives are NMDA receptor antagonists, glutamate system affecting drugs. And the main one that I'll probably mention towards the end of our talk today is the ketamine. And it's one that's shown a lot of potential for therapeutic treatment of depression and also substance use disorders. However, most of my talk today and most of my work has been focused specifically on what we call these classic psychedelics. And these are drugs that impact the serotonin 2A receptor, among others, but that's what seems to be one of the main pharmacological triggers of their drug effects. And when I'm talking about classic psychedelics, what I'm specifically referring to are these drugs, most of which are found in nature. So psilocin, which is what psilocybin is broken down into in the body. And psilocybin is found in about 200 different species of mushrooms. DMT or dimethyltryptamine, which is found in the mammalian brain, human brains, and also in plants. And so that's also found in ayahuasca, which is a sacramental psychedelic brew that's used in South America by indigenous cultures. Mescaline, which is a classic psychedelic that's found in different types of cactus, specifically peyote and San Pedro, and has also been used by indigenous cultures. And then LSD. So LSD is a little bit different because it was synthesized in a lab, but it was made out of ergot, which is a type of fungus. And so these are some of the classic psychedelics that I'll be talking about today. However, I'll be really focusing in primarily on psilocybin. And I said psilocybin is found in about 200 different species of mushrooms. They grow all over the world. And people have known about these mushrooms and have used them for years and years. And in fact, these are ceremonial mushroom stones that were found in Guatemala. And they date back as far as 3,000 years old. And what they show us is that humans have a long history of use and relationship with these psilocybin-containing mushrooms, and that oftentimes they were considered a sacred part of their culture. And in terms of modern understanding and contact with these types of mushrooms, Maria Sabina, who's pictured here, is a Mexican woman, a curandera, who is using these types of mushrooms herself in her culture in northern Mexico when she was approached by a mycologist named Gordon Wasson in the 1950s. So she brought him some of the mushrooms to explain to him what they were able to do, and that led to further scientific exploration and kind of helped us pave the way to where we're at now, some of which I think was not done ethically, but we'll get into that later. Even before Maria Sabina and she was able to introduce those psilocybin-containing mushrooms to Wasson, historically, one of the big landmarks of psychedelic discoveries was this man here, Dr. Albert Hofmann, who was working at Sandoz Laboratories in Switzerland. He was a medical chemist, and he was exploring different types of medications that they could make off of this ergot, which is a fungus that grows on different types of wheat and rye. And he first synthesized LSD in 1938. It sat on a shelf for about 5 years before he went back to try to take a second look at it, realized it had these very powerful psychoactive effects. And that really set off the beginning of our 20th century scientific research with psychedelics in 1943, when then Sandoz began producing LSD at a high rate, and then providing it free of charge to researchers and scientists all over the world to do research with. So that kicked off an early wave of research with these drugs. At the time, the word psychedelic didn't even exist yet. It wasn't coined until 1957, when Dr. Humphrey Osmond, who was doing some of this research with LSD and similar compounds, was trying to find a better name for them, because they were called hallucinogens, they were called psychotomimetics, they were called a number of different things, but the different names, many of the researchers felt didn't really characterize the effects accurately, and he felt psychedelics was a little bit more on the nose in terms of how do we describe the effects of these drugs, and specifically psychedelic means mind revealing. So he thought that these drugs sort of revealed or uncovered things that were already inside of our minds, and so that's where we got the word from back in 1957. Before I move forward and talk about some of the early clinical research that happened in the 1950s and 60s, I also like to just dispel some myths about what exactly it is that psychedelics are and how they're used, because I think there's a lot of misinformation and misunderstanding about these substances. I also like to think about this from this perspective I call psychedelic omnism. This omnism is the idea that there's valuable information that we can get from different perspectives, and that they all have valuable knowledge that we can tap into. But it's still important to see that they are different, and so they're not all the same. And so a lot of the work that we do here at Hopkins is focused squarely on therapeutic and medical approaches to using psychedelics. But as I mentioned before, there are a lot of spiritual and traditional uses that date back far longer than our therapeutic medical models. And alongside that, there's been a long history of people using these types of substances, both recreationally and for personal exploration, which we might call psychonautic type use. And so all of these have valid perspectives, but it's important to know what the use is that we're doing when we're practicing with these or when we're studying these, because they're not all the same. And the intentionality behind these different types of uses are not all the same. But coming at it from this medical therapeutic model, which is where I'm be focusing today, there were a number of different models of psychedelic type therapies that were developed in the early days in the 1960s. Some of them were using what they called a psycholytic approach, where they would use a low dose of the psychedelic drug like LSD at the same time as doing talk therapy. A lot of that talk therapy was focused on what you might think of as more Freudian or psychoanalytic tradition, just because of the era. There were other groups that just tried to use these psychedelics as standalone medications. So they would just give people high doses of the drug and see if they got better. Oftentimes they weren't getting very good results with that approach. But one of the approaches that was developed here in North America by Osmond and others was this, what we call psychedelic therapy approach. And that typically used one or a few very high doses of the psychedelic drug that was intended to produce an overwhelming, transcendent, or peak experience that then helped to catalyze a therapeutic process. And that seemed to work quite well, and it actually is a model that we tend to practice in a lot of the clinical trials that we do here today. So before we get to talking more about the contemporary research, I think a lot of the early research is very telling and interesting, and you can see this is one of my favorite studies that was done here in the Baltimore area and published in 1973 with 74 men who were leaving incarceration, who had a history of opioid dependence, mostly heroin use, and as a condition of their parole, they were coming back for weekly drug urinalysis to test whether or not they were still using opiates after their release. About half of these men went to a halfway house for a month and got a single high-dose LSD treatment with group therapy before and after. The other half of the men were in a control group, and they randomly just were released into their communities and allowed to go about their daily business. And what we see here is the number of drug-negative urine samples in the group that got the LSD treatment versus the group that got the control or treatment as usual being released without any sort of treatment. And you're seeing that across the board, all the way out to a year after this single LSD treatment, you're having higher levels of abstinence in the LSD treatment group. So, that obviously in the case of our current opioid epidemic is really compelling data to look at. And, there were more types of studies like this. This is a nice meta-analysis looking at 5 different studies that use high-dose LSD treatment versus non-psychedelic control treatments, and showing that on average, the people who got the LSD treatment, which are on this side of the fence here, were having about twice as good odds of improvement in terms of their alcohol misuse. So these were LSD studies for alcoholism specifically, as compared to the people who got the non-psychedelic control group. So again, that's very promising. But when you look at the data little bits at a time rather than pulling them all together, you got equivocal results, which is part of, I think, the noise that was happening due to the use of different types of therapeutic models. One really good example is this study that was done by Smart and colleagues, published, I think, in 1966. But basically, they took 30 inpatient alcohol treatment condition groups, and 10 of those people in each group got a different treatment. One got high-dose LSD, one got high-dose got a moderate dose of ephedrine as a control, and the others got treatment as usual, which was talk therapy. And you'll see that the ephedrine and the LSD groups had about a third of the patients improve, and the treatment as usual control group got about a fifth of the patients improve, but it was not statistically significant, and there's not a big difference between these 2 different types of drugs. But I think the reason that you saw not very good results here is because the patient was placed in a room, strapped down to a bed, given 800 micrograms of LSD, which is a very high dose, and given very little supportive therapy or counseling before or after. And as a result, you saw only about a third of them improving using that method of treatment. Using the type of treatment methods that we are now using, the psychedelic therapy approach, you saw other groups that were looking at treatment of alcoholism that were finding closer to 53% of their patients were improving after high-dose LSD as controlled, compared to 33% in a control group. So this is much more promising, seeing that about half or even more than half of the patients are showing improvements after a single high-dose LSD session. And these are the types of results that were found in the early days of the research before 1970. And I say before 1970 because while this research was going on in the laboratory, outside the lab, there was also this sort of era of political upheaval, the 1960s, and there was, the civil rights movement, the war in Vietnam, women's rights, all this different types of stuff that was going on. And many of these groups had adopted LSD, psychedelics, and cannabis as part of their counterculture. And that really led to significant backlash, specifically in 1970 and 71, when the Nixon administration created the Controlled Substances Act, which then puts the psychedelics and cannabis in Schedule 1, which is considered the most dangerous and restricted class of drugs, and then made it much more difficult for people to pursue this line of research. So after 1970 or so, there was a lot less work in this area until very recently. And for people interested in the history of the war on drugs, I think this is a fun book that kind of walks us through that by Johann Hari. But as I noted, we did kind of see an increase. This is a number of papers published about psilocybin between 1958, when Maria Sabina first brought those mushrooms to Gordon Wasson, through 1970, when they became illegal. And then you saw a gradual decline where we're seeing 10 or less scientific publications per year through the turn of the century. And right around 2000, we're starting to see an uptick. And by now, actually, I should probably update this because we're seeing lots and lots of papers published, lots of research, and lots of interest, both from scientists, but also in the popular media. And so you're seeing more and more of these types of stories like, do LSD and magic mushrooms have a place in medicine? But it's funny to kind of go back and look at the history because it's really a sort of what's old is new again. Specifically, some of those studies I showed you were featured on a CBS Reports documentary from 1966, the Spring Grove experiment. And over 50 years later, CBS sent Anderson Cooper here to the lab to talk about the psilocybin research that's happening. And so you really kind of see us doing a full circle of interest in this type of work. And it's encouraging, though, because the media and public have really shown a lot of interest. So the work that's been done at Hopkins has been seminal to setting up a lot of the psilocybin work, particularly looking at therapeutic focuses. But a lot of this started with work that was done by Roland Griffiths, Bill Richards, and others. This was before I got here. But in 2006, they published a paper of 36 healthy volunteers just looking at how they responded to high-dose psilocybin in a laboratory setting and how those effects unfolded over time. So what were the persisting effects? This was followed up by more research in healthy volunteers, but a lot of that started to push us towards looking at some of these more therapeutic angles, specifically looking at things like cigarette smokers, cancer patients, effects on spirituality, but also effects in major depression. And now we've got just more and more studies that are in progress or that are underway, including studies in patients with Alzheimer's disease, chronic Lyme disease, obsessive compulsive disorder, and studies completed with people with anorexia as well. So there's just a lot more work to do, and we're in the midst of doing a lot of that. A lot of that work was actually funded through philanthropic means. So typically NIH funding is one of the major sources for scientists doing work in the US. They were not really funding psychedelic therapeutic research for a number of years. And actually, I think we got the first grant in about 50 years to do psychedelic therapeutic research here. But because of that, before we got that grant, we were talking to philanthropists, and we were able to get money to open the Center for Psychedelic and Consciousness Research back in 2019, which has allowed us to really dig in and start exploring new directions, which is exciting. To talk briefly about the course of treatment, and I should really insert another slide here, but before we get to the drug sessions, there's often an intensive screening process that happens that includes things like a physical exam, medical history, and mental health history to assess if people are safe to receive the treatment. And before that, and before the drug sessions happen, if they're deemed eligible for these studies and seem to be safe candidates, excuse me, then we also go into a preparatory counseling process, which takes usually several weeks before we get into the drug sessions. But that's all what sets the stage for doing these drug dosing sessions, because a lot of what I just described is pretty similar to your normal medical and therapeutic protocols. But once you get to the drug sessions, you start to see things that are a little different. Specifically, we have these 8-hour psilocybin dosing sessions that are conducted here at our lab in a living room-like environment. We have 2 monitors present throughout the session who are with them not just during the dosing, but before and after in these preparatory and, as we call them, integration meetings to talk about the experience. But really, during the experience itself, during the drug dosing, we take a very hands-off approach, and we ask participants to lie down on a couch, to wear some eye masks that cover their eyes, some headphones that play a program of music, and then we just tell them to pay attention to what's going on in their minds and to trust, let go, and be open. So it's very non-directive, and this is kind of a mock session, so you can get an idea of what the rooms look like and what one of these sessions might be like. Typically, if a person is feeling like they're okay, we check in with them periodically and we check their vitals and stuff. And if they're not experiencing any distress or telling us they're having any problems, we kind of leave them alone to have their experience. And towards the end of the day, they'll sit up and then they'll start to tell us more about what they went through. But if they do start to have a difficult response, particularly if they start to get scared or anxious, that's why we're there, so we can help talk them through that and just give them a little bit of support, which is typically more than enough to get people so that they're okay and feeling like they can make it through. So some of the early research from Hopkins was really focused on what are the acute effects of the drug. When people are under the influence, what are they having or experiencing? And one of the main takeaways from this study with healthy volunteers was that people did have these very powerful, what we call mystical type experiences. But really what that means is this experience of oneness or unity, this feeling like all is one. It's much higher after people receive a high dose of psilocybin than when they got a control treatment, which was methylphenidate or Ritalin. So they're coming in, they've been psychologically prepared with monitors, and they're either receiving under double-blind conditions high-dose psilocybin or methylphenidate. And what we found was that the people who were getting psilocybin had higher rates of these types of experiences of unity, deeply felt positive mood like love and peace, and intuitive knowledge and sacredness. So these are some of the things that they would describe their experience as. So that's interesting because the drugs are different and producing different effects, but that makes sense pharmacologically because they work differently. But what's more interesting is that when you go back a couple of months later to ask people how they're doing after these dosing sessions, and the sessions were spaced out so that there was not a sort of bleed over effect, we would ask them after 2 months after a psilocybin session, how's your well-being and life satisfaction? And many of them, actually the majority, was saying that they were having moderate or very high increases in their well-being and life satisfaction that they attributed to their psilocybin experiences. Whereas the majority of people 2 months after a methylphenidate session said either they didn't notice any changes or maybe they had a slight positive change. So that's actually one of the first indications we have that these folks are not just having different experiences when they're under the influence of the drug, but that seems to last a couple of months at least afterwards. And that is what gave us the thought that doing this with the therapeutic populations would make a lot of sense. Interestingly, when you go back and then ask these people over a year later after their experiences, they're still saying that the psilocybin experiences were considered some of the most personally meaningful and spiritually significant experiences of their lives, and that they also felt that there was positive behavior changes and increased well-being from those experiences. And you can see that the number of people that are saying that is the case diminishes very little between 2 months and 14 months after the experience. So those types of long-lasting effects are very interesting and unique because you don't usually see a drug that has effects that last a month or more than a month after someone takes it. And so that really has paved the way for what we're seeing now as an explosion of research. And I'm going to start right here with depression. And I know that this specific forum is for people with HIV and other types of illnesses, but often, there's these comorbidities I'm sure you're well aware of, including things like mood, anxiety, substance use issues, post-traumatic stress. And so that's where a lot of the bulk of the work has been on psychedelics. I will talk a little bit more squarely about a study that is more relevant for this population momentarily, but I want to just kind of start with the meat of it. And a lot of that meat has been focused on depression. And specifically, there have been now a number of studies published using 1 or 2 high doses of psilocybin and finding that they have long-term antidepressant effects that last months or longer. So this is in a study that was published recently in 2021 from a group in London. And what they found was that after 2 psilocybin doses, you're seeing greater increases on average in depression that lasts out to 42 days after the first dose, as compared to daily dosing of escitalopram or Lexapro, which is a standard and approved antidepressant. So you're seeing these folks are improving with the Lexapro, but these folks who got the high dose psilocybin are improving even more, and that lasts just as long as the Lexapro, which they're taking daily, but they're only taking the psilocybin twice in the same period. We found similar findings in a study published from Hopkins here, and actually these results we've now gone back to look at. You're seeing the decrease in depression after the psilocybin dosing. It stays out to 8 weeks post-dosing, and then also that seems to last out to a year now. We've published data showing that these same patients in the same study, a year later, a majority of them are still experiencing reductions in their depression from baseline, and that's statistically significant. And that's also true for groups. And this is a study that was just published from a group in Switzerland, showing that the placebo with talk therapy versus psilocybin with talk therapy has significantly different impacts in terms of reducing depression, with greater reductions in the group that got the high dose psilocybin. And finally, this is the largest such study that's been published and conducted to date. But in this study, you had 233 individuals who either got 1 milligram psilocybin in the gray line right here, 10 milligrams psilocybin in the green line right here, and 25 milligrams psilocybin in the blue line right here. And what you're seeing is they're all starting off at their baseline scores of depression, and then we're looking at how much of an improvement or a decrease in those depressive symptoms are you seeing after either receiving 1, 10, or 25 milligrams. And so everybody has a decrease after the drug dosing, so that's interesting. And that seems to sort of level out over time to this sort of modest decrease of about 6 points. And that seems to also be pretty consistent, whether you're talking about 1 or 10 milligrams psilocybin. However, the people who get the 25 milligrams psilocybin get about twice as much of a reduction as the 1 milligram group right off the bat. And that continues to stay significantly below the baseline, more than 10 points below baseline scores, all the way out to 3 months down the line. So that's after one single dose of the drug. And it's very promising to see that this is something that even in these larger studies is carrying forward. More relevant to this group perhaps is this is a small study that was done in 18 long-term AIDS survivors. They were all men, and they were on average about 60 years old. This was done in the San Francisco Bay Area. And what they got was 8 to 10 group therapy visits with 1 high-dose psilocybin experience interspersed within that. And what they found was that with this group, there was a clinically meaningful change in demoralization, meaning that their levels of demoralization and psychological symptoms were improving significantly, and that lasted up to 3 months after the drug dose. There were also reductions in symptoms of PTSD and complicated grief. And so these are the types of things that, again, psychiatric comorbidities are particularly important in this population, and that it does show that this is very feasible to do a group therapy intervention that could be helpful in this population and probably many others using psychedelic therapies. So this is the data from this study specifically on their demoralization levels, showing that you start off rather high on average, and then that comes down a little bit with the group therapy, but it takes a sort of precipitous drop after the dosing, and that stays lower after the dosing up to 3 months. And of course, if you look at the individual subject data, you'll see some people don't really get better. Some people get better, then they get worse again, then they get better again. And so as we know from working with patients, from real people, things happen in life, and they're kind of, there are going to be ups and downs. But really, on average, when you're looking at these types of treatment effects, it's suggestive that the psilocybin therapy seems to be helpful in reducing things like demoralization. This is PTSD symptomatology, and this is complicated grief. And again, you're seeing these reductions that kind of go further down after the dosing and stay down out to 3 months. Interestingly, in terms of our adverse events in this specific study, they're very similar to what we see in many of the others. You have hypertensive reactions. People have increased blood pressure and heart rate, and that can go rather high, but usually is quite manageable with the doctor if we need to. Sometimes there's some intense anxiety that people have under the influence of these high dose psychedelics, as well as things like nausea and headache and even paranoia. However, there's not a lot of what we would call serious adverse events, things that are life threatening. And we see after the fact people do develop headaches once in a while that typically tend to be mild, and may have other mild side effects like fatigue or insomnia. But then there are things that can come up like post-traumatic stress flashbacks after the session, and exacerbation of anxiety that can lead to bad results, such as relapse to drug use. And so it's really important to paint the picture here in a fair and balanced way. You know, these drugs do have side effects, and they're not always predictable in terms of how people will respond. But on average, what you're seeing is that when we use them, they're pretty safe, and they also tend to lead to long-term improvements in a lot of different mental health domains. That also really carries over to work with substance use disorders. And to date, a lot of the work is focused on either treating alcohol use disorder or tobacco dependence. And this is a nice small study that happened, a pilot study published back in 2015 by a colleague, Dr. Michael Bogenschutz, showing percentage of drinking days and heavy drinking days are significantly reduced after 2 doses of psilocybin with motivational enhancement therapy, and that those number of drinking days stay reduced even up to about 9 months after the beginning of treatment. And so that's a nice durable effect to see in people with alcohol use disorder. And this is a larger randomized control study using either talk therapy alone or talk therapy with psilocybin in people with alcohol use disorder, and showing that consistent with these other results, the folks who got the psilocybin with the talk therapy did better on average and over time, all the way out to about 9 months down the line, than the people who got just the talk therapy alone. So that's why I do talk about these types of interventions as tools, because when you use the psychedelic, you're also typically using some form of counseling or talk therapy, and the drug itself seems to catalyze that process or make it more effective in a way that could be very useful in a clinical standpoint. Some work that I've done with colleagues, including Matt Johnson, Roland Griffiths here at Johns Hopkins, has also been very promising for treating cigarette smokers who want to quit. And this is similarly from a very small pilot study that we published back in 2014, showing that using cognitive behavioral therapy with 2 or 3 high doses of psilocybin ended up with about 80% abstinence rates at 6 months after treatment, and that people a year later, or even 2.5 or more years later, were still, the majority of them were still biologically verified as abstinent from smoking. And so those are really high numbers when you're talking about trying to get people to quit smoking, because usually at about 6 months, you may get anywhere between 25 and 30% with the best available treatments. And so this has actually opened the door for us to do a study that we're finishing now in 82 cigarette smokers who are getting either CBT with nicotine patches or CBT with 1 high dose of psilocybin, and then coming back in for their follow-ups about 3, 6, and 12 months after the quit day. And this is a study design there. The active treatment is about 3 months long with the CBT, and then the dosing right in the middle here on week 5, or starting the patches here on the same day when people are starting to quit. And then 3, 6, and 12 months later, we follow up to see if they're smoking. And so far, what we found is more than half of the people who got the psilocybin treatment are abstinent through the 12-month follow-up, and between 30 and 40% of those people who got the patches are abstinent all the way through the 12-month follow-up. Obviously, these results are still preliminary since data are still rolling in and we're waiting, but it's looking very promising that this is something that has a lot of clinical benefit for a lot of different patient populations. Briefly, I'll talk a little bit about some of what, consider the risks of the drug. I did mention some of the side effects. In one of our studies with healthy people, we had a good number of them, 40% actually, who had extreme feelings of fear of insanity, or feeling trapped during their experience. So that's not uncommon. This typically happens at the high end of the dose range. But when we've done this with now more than 400 people actually, and at this point, we're not seeing any recorded cases of things like hallucinogen persisting perception disorder or flashbacks or other types of psychiatric symptoms after the fact. And so that seems to be a pretty good safety, pretty good in terms of our safety record. We know these drugs, specifically the classic psychedelics, are physiologically non-toxic, meaning that there's no way to really have a fatal overdose like you could have from alcohol, opioids, benzodiazepines. But there are risks of increased blood pressure and heart rate. They can interact with certain types of medications like MAOIs. We do know, though, also these drugs are not really addictive in the same sense that a lot of classic drugs of abuse are. They build with rapid tolerance and there's no withdrawal syndrome. So there's a very low rate of past year hallucinogen use disorder. And most of that is related to other types of drugs like MDMA and PCP and not these classic psychedelics. So by and large, when you're looking at the relative dangers of both addiction and overdose, drugs like LSD and psilocybin fall low when you're comparing to drugs like heroin, nicotine, cocaine, or alcohol. And this is, true when you have a number of different types of experts weighing in on the harms related to the drugs. Drugs like LSD and psilocybin tend to fall very low on that spectrum. Nevertheless, for some people, they do talk about developing an HPPD or hallucinogen persisting perception disorder, which includes things like ongoing visual and perceptual problems and distress. And that's pretty low incidence as far as we know, but it's about 5% of recreational users. And it doesn't seem to really happen much or at all in the participants that are very well screened and prepared in our laboratory studies. But again, the screening is an important part of the process because we're catching people who probably shouldn't be getting these treatments. And that includes people with a personal or family history of psychotic illness or even prodromal symptoms like disordered thought or speech, paranoia. Also, people with a personal or family history of bipolar mood or mania are some of the people that we would screen out because we don't want to exacerbate a potential psychosis or a manic episode. When we talk to people about their use of the drug outside of these clinical settings, they do describe challenging experiences, including things like putting themselves or others at risk of physical harm, acting in aggressive or violent ways, needing to seek medical or psychological treatment during or after taking the drug, and very small numbers of people even talk about enduring psychosis or suicide attempts after taking high-dose psychedelics. So again, there are risks involved. But the reason we use a very intensive screening and preparation and aftercare process is to try to mitigate those risks. So I realize we're running low on time here, but I want to talk a little bit more about the brain effects and the psychological effects before I move to questions. And what you see here is a nice picture of the connectivity analysis of a person's brain and its communication when people are under the influence of psilocybin versus placebo. And obviously, you're seeing a lot more crosstalk between brain regions on psilocybin than when people are on placebo. And that seems to carry over even a week and a month after one high dose of psilocybin. People's brains are still acting differently, particularly in key emotional regulation areas like the amygdala and in areas of the default mode network like the anterior cingulate cortex. These changes happen and continue to persist for up to a month later. And changes in, for instance, amygdala reactivity are also correlated with things like reductions in major depressive symptoms. So we're noticing that some of these brain effects happen during the drug and some of them are happening after the drug. And those also seem to correlate with some of those antidepressant effects, for instance, that we found. There's also been a lot of really interesting animal research suggesting that these drugs can create new brain cells or new connections between brain cells, specifically promoting what we call neuroplasticity, where new branches between the brain cells are growing after the drug is given to an animal, and that those new branches persist for up to a month after the drug was dosed even a single time. And so those types of brain changes also seem to be related to things like reductions in animal alcohol consumption. And so it's not just humans that drink less alcohol when you give them psychedelics. Animals do the same thing. And so we're starting to tease apart some of those brain mechanisms as to why that is. For humans, one of the big things we found is that the psychological effects, specifically this mystical type experience or those unitive experiences, seem very important to long-term changes in terms of therapeutic benefits. And I like to think of this as a sort of altered state of consciousness that allows us to think about and see ourselves and our problems from a different perspective. And that by using psychedelics alongside therapeutic interventions, we're able to then destabilize some of these unhealthy patterns of thinking and behaving to try to create new and healthier patterns for people to have improved mental health outcomes. You know, some of the things that we found so far is that with cigarette smokers, they have reductions in craving and increased confidence to abstain that correlates with the greater meaningfulness of the psilocybin experience and the greater mystical type of effects that they have during the experience. And people often talk about this feeling of connection. And I like this quote from Johann Hari, who wrote the book Chasing the Scream. You know, the opposite of addiction isn't sobriety, it's connection. And so this idea that the drug seems to create a connected state in the brain, but also this connected feeling that people describe seems to be therapeutic, almost in an opposite direction to a traumatic event that can create PTSD and ongoing symptoms. You seem to see something opposite happening in psychedelic therapies where the drug is administered, creates these mystical type effects, and has ongoing benefits in people. And so when they describe these experiences, and I'll mention briefly, these are from our cigarette smokers who never met, never spoke to one another, but 6 months after experience, we asked them what was most salient to them about their experience. And many of them had things to say like this: it changes what I believe, we are all one and divine, the awareness that all is one, realization I'm a piece of the puzzle, oneness with the universe. So that seems to be a common feature. And even in cancer patients, the mystical type effects are correlated with reductions in anxiety and depression. And this is also true in people who receive ketamine for cocaine addiction, and finding that the people who had the most improvement in their cocaine problems were people who had more mystical type effects during ketamine. And this has also been borne out by research with people who took ketamine for antidepressant effects, found that more antidepressant effects were associated with greater unity and spiritual experiences during the ketamine. So there's a lot of future directions I don't have time to go over, but there's a lot of different types of substance use disorders that are being studied. Psilocybin specifically is moving into phase 3 trials for depression, meaning within the next 3 to 5 years, you could see this as an FDA-approved treatment. Will not be take 2 and call me in the morning. And it won't be like cannabis dispensaries, but it'll be much more like getting surgery. And that means it's going to happen in a controlled setting by trained professionals, and there'll be substantial preparation and follow-up. There's also lots of interesting issues to discuss about the cultural context of psychedelics, issues of equity and diversity, but we're running out of time, so I'm just going to move on to the end here and say thank you all for your attention, and thanks for inviting me today. And I'm just going to leave my email here in case anyone has any questions that we don't get to in the Q&A now. And otherwise, I'll just open up the floor to questions, and I think I'll stop there.
Thank you so much, Dr. Garcia Romeo, for that amazing presentation. We do have several questions right now in the Q&A pod. I just want to let everyone know that today's speaker did say that he can stay an additional 10 minutes after the call. So if you're able to stay that additional 10 minutes and for the questions, we invite you to stay with us. If you have your hand up, we're going to start with the Q&A pod. And if we have time, I will open up your line to ask your question. But if you can use the Q&A pod, we ask that you use the Q&A pod. So we'll go ahead and get started with our first question. I'm curious about what efforts are being made to ensure research uses don't infringe upon the ability of indigenous people's access. Is that a consideration when planning research?
No, because we use lab synthesized psilocybin, which is just made in a laboratory, which has nothing to do with indigenous use. There are other types of substances like ayahuasca and peyote, which may come from natural sources, but those are being studied at a less wide scale than psilocybin, which is being studied more so, and again using lab synthesized psilocybin.
Great. Are these procedures only substance versus substance, or do they include symbolic, transcendental, shamanic healing aspects like Maria Sabina, Jacobo Greenberg, and Salvador Roque?
We don't use those types of shamanic or more like Roque's type of therapeutic techniques, but certainly the content of the experiences can be very much what you might consider transpersonal or altered state, including symbolic archetypal imagery, past lives people talk about, or seeing their relatives. So there's a lot of really interesting stuff that comes up. But again, we take a very non-directive approach. We're mainly just trying to help people typically with a target therapeutic indication, and trying to make sense of or make meaning of their experience. And so that tends to come from a very open and supportive framework, but we're not using any sort of specific shamanic techniques in the work that we're doing. It's much more, I would say, humanistic Rogerian counseling. At least that's the style that I typically use.
What are your thoughts on kratom?
Oh, well, that's interesting. That's a very different type of drug, but I'm also an expert on that as well. And it's fascinating. It's a plant. It's from Southeast Asia. It's related to coffee, and the leaves have about 40 different alkaloids in there, which are a different kind of opioid. All the opioids we know about came from the poppy, which is a whole different class of plants, and they all come from the structure of morphine. And then you have kratom, which has mitragynine in it, and that's a whole different type of substance. But it's a legally available supplement. It seems to be safe. And for most people, some people do become physically and psychologically dependent. So, it can be habit forming, and some people can have withdrawal. But we have documented hundreds of cases of people who said that they use kratom to stop other types of substance problems, specifically, for opioids. But it's also been cited for helping people stop misusing alcohol and other types of drugs. So I think it's got a lot of promise and potential, but it's not very well studied as of yet.
Are you also studying ibogaine?
We're not because, well, there's a number of reasons, but first of all, the experience lasts about 20 or so hours. So that makes it logistically complicated. Also, people die from ibogaine just because it has cardiotoxic potentials. We could obviously mitigate that by using EKG and heart monitors and having doctors on site, but it becomes very expensive and ungainly. So no, we have not used ibogaine.
The setting trust, let go, and be open are the most important things to remember when going into a session. Would you mind sharing thoughts on people who resist the medicine, if any? A lot of have control issues, which can cause for the experience to be difficult if don't allow for the medicine to do the work.
Absolutely. Yeah, that's a very good observation. It's weird because telling people to trust, let go, and be open is not very informative in many ways. And there's people, like you said, who have control issues who that's specifically the problem. They have a hard time in life trusting, letting go, and being open. And so that also transfers into their session. The best thing we can do for them is try to build a trusting relationship where they feel like they're with people that understand them and who are able to keep them safe. And hopefully that allows them to trust and to go into the experience that way. But yeah, often you see a lot of resistance, also a lot of expectancy. People think that their experience is supposed to be one way or another. They want to steer the ship, if you will, and the experience is not something that you can necessarily control in any way. And so, yeah, they can have a difficult time. They can experience strong anxiety, strong paranoia, and fearfulness. And all we can do is just try to shepherd them through that and try to help them to move from that into a more open state. But I've seen people who are not able to get there, unfortunately, and it's a shame, but it's hard because we have a limited time with them, and it's not something that comes easily to everyone.
Research came out this week linking serotonin to heart valve disease. They specifically focused on the potential implications for SSRIs. MDMA, however, is known to cause similar valve disorders when taken chronically or in high doses. Do you anticipate similar potential side effects for other classic psychedelics, or would the dosing, such as 1 to 2 doses, possibly not repeated, negate these worries?
The dosing, you're right, would negate the worries, but there is a potential for repeated chronic microdosing, which a lot of people are talking about and doing, to create some of those valvular heart valve problems. And actually, this happened too with fen-phen, which was a drug for weight loss years ago, and it had this serotonin 2B property. And so a lot of what we're talking about has serotonin 2A properties, but the serotonin 2B chronic administration causes these heart valve problems. And psilocybin does have serotonin 2B related effects. And so people who chronically take those could potentially develop similar problems. But by using just a few high doses, that should be safe. And that's true also for MDMA, because those treatment protocols tend to use a similar model where you have about 3 months of treatment with 3 high doses in there. And that doesn't seem to exacerbate any long-term problems.
How long do the positive effects of psilocybin last? Are individuals prescribed antidepressants able to stop taking them after psilocybin?
Well, usually we wouldn't give someone who's on antidepressants psilocybin because they can interact. And so many of the people who come to us either had tried antidepressants that weren't effective and are not on them, or had tried antidepressants, are still on them, but find them that are not effective and taper off of them with their doctor and then join the studies. And when they come in for an antidepressant study, for instance, with psilocybin, so they're not on an antidepressant medicine, many of these folks are able to have benefits that last months or longer afterwards and don't get back on an antidepressant. Some of them have benefits that last, but then they feel like they do need to get back on an antidepressant. So it's still a work in progress for us to understand how long the effects last, who they last for, and whether repeated dosing might help as well. So having another dose in 6 or 12 months, for instance, might be useful perhaps to avoid going back on antidepressants. But yeah, ultimately, it's an open question, I would say.
And what are you looking for when considering good candidates for these studies?
It depends on the study, but mainly that they meet inclusion criteria. Do they have the specific condition that we're looking for? And do they not have some of these exclusionary criteria like history of psychosis, history of mania or bipolar mood, or current cardiovascular problems? That's the main thing.
And in the group settings, group session study, was the psilocybin dosed in a group setting, or was that an individual session?
Great question. So that was done with group therapy before and after the drug dosing, but all the drug dosing sessions were done individually. So everybody had their own separate dosing session with the monitors, but they would all come back together to talk about them afterwards in these group therapy sessions.
What's the research behind as to why psilocybin can help drug addiction, but specifically may cause methamphetamine relapse? What is it with methamphetamine that psilocybin may have the opposite effect?
No, it's not that with methamphetamine, psilocybin might have the opposite effect. And actually, they're working on a study now to use psilocybin treatment for methamphetamine use disorder. And a friend of mine is doing a study with psilocybin for cocaine use disorder, which is looking really promising. So really, I think it was situational in that case. Mainly, this was a person who had a history of not only demoralization and AIDS survivor, but also had a personality disorder and also had a history of methamphetamine use, which was in recovery. But there was something about the psilocybin experience that was sufficiently destabilizing that it set off some panic and anxiety symptoms. And to kind of deal with that, what ended up happening was a relapse of methamphetamine use. I would say that's a rarer case, and we often would exclude a lot of folks on the basis of personality disorders or a history of, recent substance use disorder. Although this fellow didn't have that, it had been long ago. So I think this was more of a situational factor of this particular person and what they were going through. I recommend reading the paper though, because they talk more about that specifically in that study.
So we do have a lot more questions. I'm just going to read probably two more. And so one additional question is there any evidence you are aware of that shows that this therapy has any potential interactions with highly active antiviral therapy, so heart for patients living with HIV?
No, and that's a good question because the drug-drug interactions are something that we're still parsing apart. One of the ones that we found recently that seems to be a no-no is lithium. So people on lithium tend to, it seems at least from the data we've been able to gather, may be more likely to have seizures when they're given psilocybin. But in terms of some of the antiretroviral drugs, yeah, I would say it's not something that we have a good characterization of yet. We'd want to look at the pharmacology mainly. And I know that there's drugs like, I think, efavirenz, for instance, which is serotonin 2A agonist also. So it could have synergistic effects with psilocybin. And so in terms of how that's impacting also antiviral effects, it's unclear. And I want to ask a real medical doctor. I'm a psychologist. So, but yeah, it's something to consider with using this with populations who have different types of chronic illness and who are on different types of medications that could interact.
Right. And can you speak to speak at all to the access, such as geographic or financial, for treatments like this?
Well, first of all, these treatments aren't available at all because they're still experimental. The people who are able to get into these studies tend to be in places like New York or LA or San Francisco or Baltimore, mainly because that's where the studies have been conducted to date. My hope is that should these become FDA approved treatments, that there'll be some sort of a provision for insurance coverage so that people can access them. And there will have to be some sort of training process for new therapists because there's not a lot of providers who've gotten trained to do this type of work. But yeah, I think ultimately that it'll be a crux of whether or not people can get this as if insurance covers it. And I hope that it will, because I think this will be really helpful for a lot of people. But if it's not insurance covered, obviously it's going to cost a fair amount of money just because of the amount of time that's involved. And that's also translated over into the clinical research because you've seen mainly affluent, mainly Caucasian participants in these studies for a number of reasons. But one of them being, we don't pay people to be in these studies because we don't usually have the funding to do so. And also they need to be able to take a lot of time off of work or childcare, and not everyone has that luxury. And so that unfortunately skews the patient population in a way it's undesirable. But again, the hope is that we can get both more diverse practitioners and participants in research studies, and that down the line, with insurance coverage, that this is something that's at least reasonably accessible, particularly to people in need with things like treatment-resistant depression.
So I'm going to ask this one last question because I feel like it kind of ties into what you were just saying. Any recommendations or advice in how to reduce the stigma and re-educating of psychedelics place in medicine therapy to clients, patients, colleagues? How can one advocate for access in mental health, especially with scientific research showing much promise?
That's a great question, and there's a lot of different things, but I think staying educated about the science, and so saying like, look, there are people now who have found these antidepressant effects in Switzerland and in London and in the United States. These have been published in the New England Journal of Medicine. So being able to find that information and send it to people, that's vetted info. That's not some, guy on the street who's telling you, these things are magic wonder drugs. So I think that that's helpful to be able to keep people well informed of what's going on. And so also just sticking with what groups like ours is doing, what groups like MAPS is doing. So MAPS has done a lot of the PTSD studies with MDMA. And so if you keep up with their work, if you keep up the work of the Hopkins Psychedelic Center and some of these other psychedelic organizations that are out there, hopefully, keeping an eye on that science and then just bringing that to people's attention is useful. But yeah, it's hard. And I think we're right now in a strange place of having to balance hope and hype. because there's a lot of hope these are going to be really helpful, but there's also a lot of hype where I think it may be overblown, or people aren't understanding the full ramifications of all this for different reasons. And so, taking a balanced view, I think, is essential to all of this.
Great, thank you. So we want to thank you once again, Dr. Garcia Romero, for your insightful presentation. And thank you everyone for your questions. We apologize that we won't be able to get through all the questions in the QA pod. And we thank you for staying to the end to hear the rest of the questions being answered. If you have not seen the evaluation, Ashley did drop the evaluation link for today's session. We would love to hear your feedback. We also invite you to join us for next month's session, March 3rd at 12 p.m. Eastern time. And this is support for adults with active substance use living with or at risk for HIV, role of sobering centers in the care of acute intoxication. If you have any questions, please feel free to reach out to me. And Dr. Garcia Romero, can you please once again drop your information? You did offer your email if people had questions, if our participants had questions. If you don't mind putting that in the chat. So if your question was not answered, if you would like to reach out to our speaker directly, we welcome you to do so. So thank you everyone once again, and have a great day.